Good afternoon, everyone. So I will be presenting a randomized phase 2 study of Osimertinib and Bevacizumab versus Bevacizumab alone as a second-line targeted treatment in advanced NSCLC with confirmed EGFR and acquired T790M mutations. It's a booster trial presented by R.A. Su et al. Second-line treatment for EGFR mutant T790M mutation positive NSCLC. We have seen in Aura 3 PFS with Osimertinib, median PFS was 10.1 months compared to 4.4 months with chemotherapy. Overall survival was also significant. It was 26.8 versus 22.5 months. So moving further, how can we improve the survival in T790M mutation? So the rationale for this trial was vascular endothelial growth factor. It plays a critical role in tumor angiogenesis and has shown to interact with EGFR signaling pathways. Increased VEGF levels in EGFR mutant NSCLC were associated with the resistance to EGFR inhibition. In preclinical studies, this combination of anti-VEGF and EGFR TKI that has demonstrated synergistic anti-tumor activity, overcoming the resistance to anti-EGFR therapy. Several studies of combining anti-angiogenic agent with erlotinib have shown to prolong PFS as compared to erlotinib monotherapy in the first-line treatment. This is how do agents actually work together to enhance PFS. This anti-angiogenic therapy can transiently normalize the tumor vessel network, improving the drug delivery and efficacy. Evidence of crosstalk between EGFR and angiogenic pathway. EGFR receptor mutation, it enhances the expression of vascular endothelial growth factor. Combining both the drugs override primary or acquired resistance to EGFR TKI. These are the trials showing result of first-line use of erlotinib in combination with Bevacizumab JO25567. It showed a PFS benefit with combination. Also, NEG 026 in this trial, erlo plus Bevacizumab combination improved the PFS. Relay was a combination of erlotinib plus ramucirumab, which has shown PFS benefit 18 months versus 11.1 months. Moving to this study, eligibility criteria was pathologically confirmed NSCLC, non-squamous that has exon 19 or exon 21 deletion, either stage 3B/C or stage 4A, with confirmed T790M mutation in the tumor tissue or ctDNA after disease progression on first-line TKI, previous exposure to maximum one line of platinum-based chemotherapy, and presence of measurable or evaluable disease and adequate organ function. Patients were randomized 1:1 to the combination, that is Osimertinib 80 mg once daily plus intravenous Bevacizumab 15 mg per kg on day 1 of each 3-weekly cycle. And in second arm, patient received Osimertinib 80 mg once daily. Primary endpoint was PFS. Secondary endpoints were overall response rate, disease control rate, and OS. Exploratory endpoints were time to failure, duration of response, and duration of clinical benefit. Baseline characteristics were comparable in both arms. Median age was 66. Female, 60% in both arms were females. 40% of the patient were of Asian ethnicity. 38% patient in combination arm were former smoker. Most of the patients had stage 4 disease, prior therapies, erlotinib or gefitinib. 70% of the patient in both arms received erlotinib or gefitinib. 26% patient received afatinib or dacomatinib. Testing material, ctDNA, 48.7% were tested by ctDNA, and tissue testing was done in 50% of the patient. 16.7% of the patient in combination arm had brain metastasis, while 10% patients in Osimertinib arm had brain metastasis. Coming to the results, PFS in the Osimertinib plus Bevacizumab arm was 15.4 months compared to 12.3 months in the Osimertinib alone arm, which is not significant. 1 year PFS was 60.3 in the combination arm versus 50.8% in the Osimertinib alone arm. In the patient who were either a smoker or ex-smoker, the PFS was significantly improved with the combination. In subgroup analysis, in smoker, the PFS was significantly higher. Coming to OS in the combination arm was 20 months, and in osimertinib alone arm, it was 24.3 months. Again, the OS was higher in patients with the smoking history. For combination, it was 31 months. Osimertinib, patients taking osimertinib and who were smoker, it was 18.6 months, and in combination non-smoker, it was 20.5 months. The probable explanation for this response in smokers was that tobacco exposure produces genomic mutation in lung cancer, including TP53 and TP53 mutations. These are associated with improved outcome with VEGFR or VEGFR inhibitors. Coming to safety, in both arms, almost 76% of the patient had any toxicity. Grade 3 adverse events were seen in 36% of the combination arm compared to 14 in osimertinib arm. Treatment-related adverse event that needed dose interruption were 30% in the combination arm and lesser, that is 9.1 in the osimertinib arm. Treatment-related adverse event leading to...
An alarm has been activated. We are investigating the cause.
So, treatment-related adverse event, diarrhea and rash, both were common in both the arms. Almost 40% of the patient had diarrhea. In the osimertinib or bevacizumab arm, proteinuria and hypertension was significantly higher.
Your attention, please. An alarm
Was significantly higher, almost 44%. Other safety signals were equal on both arms. To conclude, this result suggests that the combination of bevacizumab and osimertinib is not associated with increased efficacy or osimertinib monotherapy. Results from ongoing studies in EGFR, TKI, and neo patients population receiving osimertinib with ramucirumab or with bevacizumab may further elucidate the role of this combination. Single agent osimertinib remains the standard of treatment in pre-treated patient harboring T790M mutation.
Ladies and gentlemen, your attention,
Thank you.
please.